This lecture will give an overview of coronary artery disease, including the universal definition of myocardial infarction. The new term chronic coronary syndrome will be introduced. Coronary artery disease or CAD is known by various names like ischemic heart disease, atherosclerotic coronary heart disease, and coronary heart disease. Please subscribe to this channel for future updates. Click on the subscribe button. Press the bell icon after that for all updates. In general, CAD is due to coronary obstruction because of atherosclerotic plaques. Other rare causes of coronary obstruction include coronary dissection, coronary spasm, and coronary embolism. Manifestations of coronary artery disease can vary from asymptomatic to sudden cardiac death as initial manifestation. Sudden death in a previously asymptomatic person is usually due to life-threatening ventricular arrhythmia known as ventricular fibrillation, which can occur in the early hours of a myocardial infarction. Symptomatic CAD is divided into chronic stable angina, now termed chronic coronary syndrome, and unstable ischemic syndromes. Unstable ischemic syndromes or acute coronary syndromes can be further subdivided into unstable angina and myocardial infarction. Biomarkers like cardiac troponin are elevated in myocardial infarction. Biomarkers are not elevated in unstable angina. Myocardial infarction includes those with ST elevation known as ST elevation myocardial infarction or STEMI, and those without ST segment elevation on ECG known as non-ST elevation myocardial infarction or NSTEMI. STEMI is usually due to acute thrombotic occlusion of a major coronary artery and will benefit from early removal of the obstruction either by mechanical means, that is primary angioplasty, or clot-lysing medication like thrombolytic therapy, or a combination of both. Coronary risk factors can be divided into modifiable and non-modifiable. The main three non-modifiable coronary risk factors are age, gender, and family history. Prevalence of coronary artery disease increases as age advances. Coronary artery disease is more prevalent in males. The greater number of close relatives in family with CAD, the higher the risk of CAD. Important modifiable risk factors are hypertension, diabetes mellitus, dyslipidemia, obesity, smoking, and sedentary lifestyle. Sitting for more than 5 hours a day is considered to give a risk equivalent to smoking. That is why many workplaces have started implementing standing desks at work. Regular exercise of at least 30 minutes on a minimum of 5 days a week is important in reducing the risk. For those above 40 years of age, it is wiser to start the exercise program in a graded pattern after a medical checkup to exclude silent coronary artery disease, which can become symptomatic with vigorous exercise. The conventional risk factors detailed above do not fully explain the occurrence of coronary artery disease. Hence the search for novel coronary risk factors. More than 100 emerging risk factors have been suggested. The widely discussed emerging risk factors are C-reactive protein, homocysteine, fibrinogen, adiponectin, plasminogen activator inhibitor 1, and interleukin 6. Chronic stable angina is a stable situation with symptoms lasting more than 1 month. It manifests as chest pain brought on by exertion and relieved by rest. It is due to a demand-supply mismatch. Usually it occurs due to reduction of supply of oxygenated blood to a region of the myocardium due to significant narrowing of the coronary artery. Supply side can be affected by anemia, which reduces the oxygen carrying capacity of blood. Severe anemia can worsen effort angina. Chronic stable angina, also known as effort angina, can also occur due to increased demand as in a hypertrophied ventricle in severe aortic stenosis or hypertrophic obstructive cardiomyopathy. Other causes which can increase demand are tachycardia due to fever or hyperthyroidism. There can be a combination of both mechanisms. For example, a hypertensive patient can have left ventricular hypertrophy along with obstructive coronary artery disease, as hypertension is an important risk factor for coronary artery disease. Chronic ischemia may also manifest as heart failure. Myocardium with chronic ischemia, which is reversible on revascularization, is known as hibernating myocardium. Large amount of hibernating myocardium can contribute to left ventricular dysfunction and heart failure. Hibernating myocardium will be viable and detectable using tests for myocardial viability like stress echocardiography and positron emission tomography, which studies the metabolic activity of the myocardium. Hibernating myocardium has reduced contraction on echocardiography, that is hypokinesia, which improves with low-dose dobutamine stimulation and worsens with high-dose dobutamine infusion. Acute coronary syndrome can be broadly divided into unstable angina and acute myocardial infarction. In unstable angina, there is no elevation of biomarkers of myocardial necrosis, while it is elevated in acute myocardial infarction. Two subgroups of acute myocardial infarction are ST elevation myocardial infarction or STEMI and non-ST elevation myocardial infarction or NSTEMI. Non-ST elevation myocardial infarction and unstable angina can also be grouped together as non-ST elevation acute coronary syndrome or NSTACS. Unstable angina is either rest angina or recent change in the anginal threshold of effort angina. Thus, chronic coronary syndrome can become an acute coronary syndrome, usually by intervention of some precipitating factors. Precipitating factors include anemia, fever, infection, hyperthyroidism, and atrial fibrillation with fast ventricular rate. A combination of factors may work together, like atrial fibrillation with fast ventricular rate in a case of hyperthyroidism. Change in the characteristics of the atherosclerotic plaque is often the reason for unstable ischemic syndromes. A plaque with lipid-rich core and a thin cap can rupture in response to hemodynamic stress. Clots can form in an ulcerated atherosclerotic plaque, which can cause sudden increase in the luminal narrowing. Alternatively, hemorrhage into the plaque can also enhance the luminal stenosis. If the lumen gets totally occluded, it usually results in an ST elevation myocardial infarction. Partial occlusions could cause either unstable angina or non-ST elevation myocardial infarction. It may also be noted that the former can progress to the latter. Typical ECG change in unstable angina is a horizontal ST depression, often in the inferior and lateral leads. Downsloping ST depression and T-wave inversions may also be noted in unstable angina. Occasionally, ECG can be normal in unstable angina. Risk is higher in those with ECG changes than in those without ECG changes. ST elevation during angina, returning back to baseline when angina subsides, is classical of Prince-Metals vasospastic angina due to coronary vasospasm. It may be noted that Prince-Metals angina is associated with obstructive coronary artery disease in 2/3 of cases. The prognosis is poorer in those with obstructive coronary artery disease. Though ECG is the first test for a person with suspected myocardial infarction, the stress has shifted to cardiac markers with publication of the Universal Definition of Myocardial Infarction. First universal definition was published in 2007 and fourth definition has been published in 2018 by the joint European Society of Cardiology, American College of Cardiology, American Heart Association and World Heart Federation Task Force. According to the universal definition of myocardial infarction, there are types 1 to 5 with a subclassification of type 4 into A, B and C. Pathologically, myocardial infarction is defined as myocardial cell death because of prolonged ischemia, that is lack of blood supply. Myocardial injury is defined as elevation of blood level of cardiac troponin above the 99th percentile upper reference limit, known in short as URL. Clinical evidence of acute ischemic myocardial injury makes it myocardial infarction. Type 1 myocardial infarction is due to atherothrombotic obstruction of a coronary artery, usually precipitated by a plaque rupture or erosion, a rise and or fall of cardiac troponin values with at least one value above the 99th percentile upper reference limit, along with one or more of the following is needed for the diagnosis. 1. Symptoms of myocardial ischemia. 2. New ischemic ECG changes. 3. Development of pathological Q waves. 4. Imaging evidence of new loss of viable myocardium or regional wall motion abnormality consistent with ischemic pattern. 5. Identification of a coronary thrombus by angiography, including intracoronary imaging, or by autopsy. Type 2 myocardial infarction is myocardial injury due to a supply-demand mismatch. Examples are a precipitous fall in hemoglobin due to acute gastrointestinal bleed or sustained tachyarrhythmia with clinical manifestation of myocardial ischemia. Type 2 myocardial infarction is commoner in females and has a poorer prognosis than type 1 myocardial infarction due to the often associated comorbidities. There may be associated coronary atherosclerotic disease. In type 3 myocardial infarction, clinical and presumed ECG evidence of myocardial ischemia are present, but the person dies before biomarker evidence can be documented. In case a subsequent autopsy shows a fresh thrombotic occlusion of an infarct-related artery, it should be reclassified as type 1 myocardial infarction. Type 4A myocardial infarction is associated with percutaneous coronary intervention. Myocardial injury in this setting is defined as cardiac troponin values above 99th percentile upper reference level in patients with normal baseline or a rise of cardiac troponin value more than 20% of the baseline value when it is above the 99th percentile URL but is stable or falling. Absolute value of cardiac troponin should be at least 5 times upper reference limit. Clinical and ECG criteria are the same as that of type 1 myocardial infarction. Angiographic criteria are a procedural flow-limiting complication such as coronary dissection, occlusion of a major epicardial artery or a side branch occlusion or thrombus, or disruption of collateral flow or distal embolization. Type 4B myocardial infarction is one associated with coronary stent or biodegradable scaffold thrombosis documented by angiography or autopsy. If it occurs within 24 hours, it is acute. From 24 hours to 30 days, it is considered subacute. Late if between 30 days and 1 year. Very late if beyond 1 year of stent or scaffold implantation. Type 4C myocardial infarction is due to restenosis after coronary stenting or balloon angioplasty with elevated troponin similar to that of type 1 myocardial infarction, but angiographic demonstration of restenosis as the cause is needed. Type 5 myocardial infarction is associated with coronary artery bypass grafting or CABG. Cardiac troponin value more than 10 times the 99th percentile upper reference limit within 48 hours of CABG is taken as the cutoff value for the definition. In addition, at least one of the following must be present. 1. Development of new pathological Q waves. 2. Angiographic evidence of graft occlusion or a new native coronary artery occlusion. 3. Imaging evidence of new loss of viable myocardium or a new ischemic regional wall motion abnormality. Please don't forget to subscribe to this channel for future updates and click on the bell icon for all updates. Thank you.